Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to my channel of Easy Medical Notes, which is a summary of standard medical textbooks like Harrison, Davidson, McMaster, Oxford, and Pocket Medicine. Yesterday we have learnt about the causes, etiology, and clinical features of various causes of chest pain. Today we'll learn how to approach a patient with chest pain in ED or in OPD. So first of all, we'll see one more classification of this chest pain. Differential diagnosis of chest pain, causes of central chest pain, and next is causes of peripheral chest pain. In central chest pain, the central chest pain is mainly due to the central structures of the chest. That can be cardiac or aorta or esophagus or pulmonary artery or mediastinum or anxiety or emotion. These are the central causes of chest pain. In cardiac, it can be due to cardiac ischemia like angina, infarction, myocarditis, pericarditis, or mitral valve prolapse. Aorta, it can be due to aortic dissection, aortic aneurysm. In esophagus, it can be due to esophagitis like GRD, esophageal spasm, Mallory-Weiss syndrome. Is nothing but tear in the mucosa of gastroesophageal junction due to retching or vomiting, or esophageal perforation, also known as Boer-Haave syndromes. This is tear, this is perforation at the gastroesophageal junction due to severe vomiting, or massive pulmonary embolism, mediastinal malignancy, anxiety and emotion. So all these causes cardiac, aortic, esophagus, pulmonary embolism, mediastinal, and emotion. All these produce predominantly central chest pain. So, what are the causes of peripheral chest pain? Peripheral chest pain. So, these are mainly due to lung, pleura, chest wall, and neuro causes. Lung, pleura, chest wall, and neuro causes. What are those? In lungs and pleura, it can be due to pulmonary infarction, pulmonary infection like pneumonia or pneumothorax or malignancy or tuberculosis or connective tissue disorders. In musculoskeletal causes, it can be due to osteoarthritis of back, osteoarthritis of thoracic vertebra, or it can be due to rib fracture or injury, acute vertebral fracture, costochondritis, inflammation of costochondria, also known as Teat syndrome, intercostal muscle injury. It can be neurological, which can be to prolapsed intervertebral disc at the level of cervical spine or thoracic spine, thoracic outlet syndrome, or herpes zoster. These are the neurological causes. So, peripheral chest pain causes predominantly are lung and pleura, musculoskeletal, and neurological. Moving forwards to the approach of chest pain. So the key investigations in cases of chest pain are: number 1 is chest X-ray, number 2 is ECG, number 3 are biomarkers like troponin and D dimer. These are the 3 key investigations which are done in a patient with chest pain. So remember, when there is a patient of breathlessness, we will do ECG, chest X-ray along with arterial blood gas analysis, but focus will be more on chest X-ray in case of breathlessness. And in case of chest pain, the focus will be more on ECG than X-ray, but we'll do all of this. In breathlessness, it is chest X-ray, ECG, and troponin D dimer. Troponin in acute chest pain, and in breathlessness it is chest X-ray, ECG, and blood gas analysis along with anti-proBNP. So any patient coming with chest pain in the ED, you should calculate the heart score of that patient. Heart score. there is something called as heart score. Based upon that, we uh, we give the patient score 1 3 4 5 6 0 to 10 score we give. So heart score is nothing but H for history, E for ECG changes, A for age, R for risk factors, T for troponins. So these five combine to make the heart score. So if the history is highly suspicious of chest pain, then we will give 2 points straight. If it is moderately suspicious, then we will give 1.8. And if it is slightly or non-suspicious, then we will give 0 point. In ECG, if it is significant ST depression, then it is 2 points, and non-specific repolarization, then 1.8, and if it is normal, then 0 points. If the age of the patient is more than or equal to 65 years, it is 2 points. 45 to 65, 1 point. Less than 45, 0 point. More than or equal to 3 risk factors or history of coronary artery disease, then we will give 2 points. 1 or 2 risk factors, then we will give 1 point. No risk factor will give 0 point. So more than or equal to 3 times the normal limit of troponins, then we give 2 points. 3 times normal. If it is between 1 to 3 times normal limit, then we'll give 1 point. And if it is less than the normal limit, then we'll give 0 point. Then what are the risk factors? Risk factors are diabetes mellitus, current or recent less than 1 month smoker, hypertension, hypertension, and hyperlipidemia, dyslipidemia, family history of coronary artery disease, and obesity. So these are the one is diabetes, smoker, hypertension, hyperlipidemia, family history, and obesity. These are the 6 risk factors. If the patient has 3 of them or a history of coronary artery disease, then we give 2 points. So if the score is 0 to 3, then we will discharge the patient to home. If it is more than 4 and less than 6, if it is 4 to 6, then we will admit the patient for clinical observation. And if it is between 7 to 10, then we will do early invasive strategies like angiography or PCI, like that. So this is the score which is very important, whether to discharge the patient, whether to admit the patient or whether to do some early invasive strategies to the patient. So if we observe here, any patient which is more than 45 years, having some 1 or 2 risk factors, and troponin is between 1 to 3, and non-specific repolarization, moderately suspicious, so this will be 5 points. 1 point for each. So any patient more than 45 years who has smoking, hypertension, obesity, diabetes mellitus, one risk factor, 1 or 2 risk factor. So more than 40 years, 1 or 2 risk factor. This is nothing but we have to test it. If there is non-specific repolarization, meaning, so in V1, V2, V3, V4, you will see a P wave, then R wave increasing, then like this T wave, like this T wave. So it is not ST segment elevation, because the J point is not elevated and it is not convex like this. This type of ECG, this type of ST elevation is called as early repolarization pattern. Okay, this is the heart score. Next, you have calculated the heart score, and you found that the patient has a score of 4 to 6 or 7 to 10. Then what will you do? Then first you need to urgently exclude or rule out these life-threatening conditions. What are those? Those are nothing but unstable ischemic heart disease, means MI, aortic dissection, massive pulmonary embolism, and pneumothorax. These four conditions we should rule out in any acute chest pain patient which is having a score of more than 4. More than 4, heart score more than 4, we should rule out. And if these are not there, in acute chest pain, we have to rule out first these four conditions. And if a patient presents with a chronic chest pain condition, then you should rule out. If not these, if these four are not there, and patient has chronic chest pain, then you should rule out angina, pulmonary hypertension of pulmonary artery, and aortic stenosis. Similarly, this is cardiac, this is aorta, and this is pulmonary artery. And here also it is cardiac, and this is aorta, and this is pulmonary artery. So stable cardiac, aortic, and pulmonary conditions you should rule out in chronic conditions, and life-threatening cardiac, aortic, and pulmonary artery conditions you should rule out in acute chest pain patients, along with one more condition, that is pneumothorax, and one more you can take, that is esophageal perforation. Esophageal perforation you can take in acute chest pain. Okay, and moving to the next one. So first, among those four life-threatening conditions, we will discuss about that. First one is the acute coronary syndrome. Acute coronary syndrome may be diagnosed with confidence in patients with a convincing history of ischemic pain and either ECG evidence of ischemia or an elevated serum troponin. So these are two conditions. If they are met, then it is acute coronary ACS. What are the conditions? One is convincing history. One is convincing history. Second one is either ECG elevation, ST segment elevation changes, or elevated troponins. So one is history, and two is one among this, ECG, ST elevation, or increased troponins. So this is enough to declare the patient to be having acute coronary syndrome. Acute chest pain with ECG changes indicating a ST segment elevation, that means ST segment elevation MI, suggests that the patient is likely to benefit from immediate reperfusion therapy. So remember that whenever there is MI, there are two types of MI. Basically, one is STEMI, ST segment elevation myocardial infarction. Second one is non-ST segment elevation myocardial infarction. Basically, what happens here in ST segment elevation myocardial infarction, if this is the wall of the heart, then partial necrosis of the wall of heart will take place in in ST segment elevation myocardial infarction, whole wall will be necrosed due to ischemia. And in non-ST segment elevation myocardial infarction, partial wall will undergo necrosis because of ischemia. So in ECG changes, you will have J point elevation. What is J point? This is P wave, this is Q, this is R, this is S. Okay, this is known as the J point. This point R and this point is known as J point. So this will be elevated like this, something like this, like this you will get. Okay. So in ST segmentation, that will be there. In non-ST segment elevation, ST segment will not be elevated. Either there can be sloping depression like this, or there can be flat like this, or only they can be inverted T waves like this with symmetrical limbs. Symmetrical limbs should be there in T waves, or there can be hyperacute T waves, tall T waves, tall T waves. So all these signify non-ST segment elevation MI. It can signify non-ST segment elevation MI if the patient has chest pain. Okay, because the management is different. That's why we should remember about STEMI and STEMI. Management and prognosis both are different. So STEMI patients are they are very benefited by immediate reperfusion therapy, either by thrombolysis, or by percutaneous coronary intervention, or by coronary artery bypass graft. These are the three things by which we manage ST segment elevation MI. In the context of a compatible history, an ECG showing ischemic changes that do not meet STEMI criteria should prompt regular repeat ECGs after 8 to 12 hours and treatment for NSTEMI or unstable angina. So if there is a compatible history of cardiac chest pain and there is no ST segment elevation, just there is no ST segment elevation, but there can be ST segment depression, or there sloping downside, or flat, or uh, or there can be inverted T waves, or they can be hyperacute T waves. If all these are there, but there will not be ST segment elevation like this. There will not be elevation like this. This is not there, but these, among these, when one can be there, so or ST segment can be normal. So if that is there, the history is compatible, ECG is showing ischemic changes, either sloping ST depression or flat ST segment depression, or inverted T wave, or hyperacute T waves, then with compatible history, this may be STEMI. This does not signal STEMI, but this can be this can be NSTEMI. This can be NSTEMI, and the treatment for NSTEMI should be given, and that is nothing but aspirin, clopidogrel in loading doses, clopidogrel 300 mg, and injection low molecular weight heparin, like enoxaparin. Dose of enoxaparin is injection enoxaparin is 1 mg per kg, or 60 mg BD you should give subcutaneously. So this is the treatment of NSTEMI. So if the ECG has compatible history, but ECG showing ischemic changes, but that is not STEMI, so you should give treatment for NSTEMI. Next point is, if an elevated serum troponin is found in a patient who has an atypical history or is at low risk of ischemic heart disease, if the heart score is less than 4 and the chest pain is atypical, then, and if these are there and troponins are still raised, then alternative causes of raised troponin should be considered. What are those alternative causes? So you can see here, these are the alternative causes where you can see raised troponins without any cardiac ischemia or without any MI. Pulmonary embolism, acute pulmonary edema, arrhythmias, myocarditis and myopericarditis, aortic dissection, cardiac trauma, cardiac surgery, non-cardiorespiratory causes like prolonged hypotension, sepsis and burns, stroke, subarachnoid hemorrhage, renal failure. So in all these conditions, troponins can be raised without any MI. So what are the changes in MI you will see? What are the changes in MI you will see? It is ST segment elevation or ST segment depression, T wave inversion, hyperacute T waves or Q waves. So in this is STEMI, and these all are NSTEMI. Okay, so see here one image. So it's a spectrum. Myocardial ischemic pain is a spectrum actually. So in unstable angina, troponins and CKMB will be undetectable. We can see here. And in NSTEMI, non-ST elevation myocardial infarction, troponin or CKMB are elevated. And in STEMI, they are elevated. So in NSTEMI and STEMI, troponins are raised, but in unstable angina, troponins are normal. That's how you differentiate between unstable angina and STEMI and non-STEMI based upon troponins and CKMB. See, there is complete blockage of the coronary artery due to atheromatous plaque. Here there is a partial blockage. So moving forwards. So next common emergency life-threatening conditions can be these four actually. So one is aortic dissection, one is massive pulmonary embolism, esophageal rupture, and one more is pneumothorax. Okay. In the absence of convincing ECG evidence of myocardial ischemia, other life-threatening causes of chest pain such as aortic dissection, massive pulmonary embolism, esophageal rupture, also pneumothorax should be considered. So when do you suspect aortic dissection? On the background of hypertension, trauma, pregnancy, previous aortic surgery, should prompt urgent thoracic CT or transesophageal echocardiography. A widened mediastinum in chest X-ray suggests acute aortic dissection, but a normal chest X-ray does not exclude the diagnosis. So in the previous class, we have learned about the chest pain of aortic dissection. So in this CT, thoracic CT scan you can do, or echocardiography you can do. These are the two, and chest X-ray shows widened mediastinum. So these investigations you can do if you are suspecting aortic dissection. Clinical features: sudden onset, rearing, ripping chest pain that migrates to the back, loss of peripheral pulses, blood pressure difference more than 20 mmHg between the arms. Neurological deficits like hemiparesis, paraparesis can be there. So these points just to remember, and pulses, paradoxes can also be there. So just remember these points: the type of pain, loss of peripheral pulses, blood pressure difference, hemiparesis, paraparesis, and pulses, paradoxes. If these are there, then you suspect aortic dissection. Moving forwards, next one is massive pulmonary embolism. An ECG in the context of massive pulmonary embolism most commonly reveals only a sinus tachycardia but may show a new right axis deviation, right bundle branch block, or a dominant R wave in V1. The classical finding of S1Q3 T3, a deep S wave in lead 1 with a Q wave and T wave inversion in lead 3 is rare. So the common condition are sinus tachycardia. Next is right axis deviation, meaning right reaches R wave will be predominantly negative and one in 1, and in 2 it will be predominantly positive. That is right axis deviation. Right bundle branch block we have learned previously. This is the P wave in the lead 2, in lead V1 and V2. So right bundle branch block, this is V1, this is Q, this is R, RSR dash pattern will have RSR dash. Okay, here P wave, RSR dash, small r, big S and big R. This is known as RSR dash pattern. We can see right bundle block, new or M pattern we can see. Next, dominant R wave in V1 meaning normally we see small one R wave and big S wave in V1, but in this case we can see R more than S, R more than amplitude of R more than S in V1. So deep S wave in lead 1 or Q wave in, with a Q wave and T wave inversion in lead 3. This is rare to see. So next is D-dimer test. If the patient is deemed to be at low risk of pulmonary embolism, a D-dimer test can be informative, as a negative result effectively excludes the diagnosis. If the patient is low risk for pulmonary embolism and you are in doubt, then just do D-dimer. If it is not raised, then that excludes a pulmonary embolism. The D-dimer test should be performed only if there is a clinical suspicion of pulmonary embolism, as false positive results can lead to unnecessary investigations. If the D-dimer is positive, there is high clinical suspicion or there is other convincing evidence of pulmonary embolism, such as features of right heart strain on the ECG, strain pattern R, S, R dash, along with like this inverted T wave. One limb is sloping, limbs are not symmetrical, or like this R, S, and this like in V1 and V2. So this is right heart strain pattern. If the D-dimer is positive, high clinical suspicion based upon Wells score. What is Wells score? We'll know next. Where Wells score describe the through that score we can know the probability whether it is low risk or moderate risk or high risk for pulmonary embolism. High clinical suspicion, and if there is convincing evidence of on ECG, right heart strain pattern, three things. Clinical history should be high clinical suspicion based upon Wells score, and ECG changes are there. And along with that, if the D-dimer is positive, then suspect pulmonary, then prompt imaging should be arranged. Prompt imaging, CT should be arranged. CT chest should be done. If massive pulmonary embolism is suspected and the patient is hemodynamically unstable, a trans and thoracic echocardiogram to seek evidence of right heart, right heart strain and exclude alternative diagnosis such as tamponade is extremely useful. Okay, so if you are having low suspicion of pulmonary embolism, and still you are in doubt, then do D-dimer test. If it is not it is negative, then it effectively excludes pulmonary embolism. If you are having a high clinical suspicion and ECG shows right ventricular strain pattern, along with that you are having a D dimer positive, then arrange for CT angiography to rule out pulmonary embolism. And if it is massive pulmonary embolism, remember Beck's triad in massive pulmonary embolism, Beck's triad. Okay, in sorry, not in Beck's, it is in cardiac tamponade actually. In massive pulmonary embolism, remember there is hypotension actually. So if the patient is not hemodynamically stable, if there is hypotension, or if the patient is not conscious, okay, not conscious, then you should do echo to seek evidence of right heart strain and exclude alternative diagnosis of pulmonary embolism, which is that is tamponade. So you should differentiate between cardiac tamponade, because that also presents with hypotension along with chest pain, no? And you should differentiate between cardiac tamponade and massive pulmonary embolism. How you will differentiate? By doing transthoracic echocardiogram. So this is the Wells score, which is used to determine the probability of pulmonary embolism in an individual. So if the clinical signs and symptoms, if there are clinical signs and symptoms of deep venous thrombosis, objectively measured leg swelling and pain with palpation in the deep vein system, then that means if the leg is swollen and if there is pain in the leg, so you give 3 points for that. Okay, if the heart rate is more than 100 per minute, you give 1.5 point. If there is immobilization more than 3 consecutive days, bed rest except to access bathroom, or surgery in previous 4 weeks, previous 1 month, give 1.5 point. If previous objectively diagnosed pulmonary embolism or deep venous thrombosis, that means previous history of pulmonary embolism or deep venous thrombosis, give 1.5 point. If there is history of hemoptysis, give 1 point. History of malignancy, cancer patients receiving treatment within 6 months or receiving treatment, give 1 point. If pulmonary embolism, as likely, more likely than alternative diagnosis based on history, physical examination, chest radiograph, ECG and blood test, then give 3 points. Means history, physical examination, chest x-ray, ECG, blood test, all suggesting nothing, MI, aortic dissection, and just everything is pointing towards pulmonary embolism, then you give 3 points for that. And this one heart rate, HR, immobilization, previous history and hemoptysis, sorry, HR, immobilization, pulmonary hypertension have 1.5 points, and hemoptysis, malignancy and all history, physical examination, chest x-ray, ECG, blood test suggesting pulmonary embolism, that is 3 points, and these are 2 points. Hemoptysis and malignancy have 1 point each. One more to revise. Clinical symptoms and signs of DVT is 3 points. Heart rate, immobilization and previous history of pulmonary embolism DVT have 1.5 points. Hemoptysis and malignancy have 1 point each. More likely diagnosis of pulmonary embolism based upon history, physical examination, chest x-ray, ECG, radiograph has 3 points. So if the score is less than 2, then it is very low probability. Okay, if the score is less than 4, just remember, don't remember this one. If the score is more than 4, it is likely probability. If it is more than 6, it is high probability, and if it is less than 4, it is low probability. Okay, so in low probability you should do D dimer to exclude deep venous thrombosis. and in cases of more than 4 to 6 core, you should you should differentiate it from cardiac tamponade by transthoracic echocardiography if the patient has hemodynamic instability like altered mental state and hypotension. And it is not massive, and if the patient has all those things, then you should manage accordingly. Next, moving to the next emergency, that is esophageal rupture. Provided it has been more than 1 hour since the onset of pain, chest X-ray in esophageal rupture may reveal subcutaneous emphysema, pneumomediastinum, pleural effusion, meaning air below the skin, air in the mediastinum, or fluid in the pleural cavity, less than 1 hour. History of onset of pain should be there. Along with this, then that suggests esophageal rupture. Then one more emergency is pneumothorax, sudden onset sharp pleuritic type of pain, unilateral silent hyperresonant chest with hypertranslucency of chest in the chest X-ray. So this is, if this is the lung and this is the lung and this is the chest wall, you will see the lung margin away from the chest wall, and you will see chest wall here. Here you will have pulmonary vessels and bronchial markings, but here you will not have any bronchial or pulmonary markings. So this will be hypertranslucent, meaning this will be more blackish, because those markings are lost, more blackish. Okay, coming to non-life threatening causes of chest pain. So pericarditis and myocarditis, these are non-life threatening causes. What are the ECG changes in this? So ECG changes are diffuse ST segment elevation and PR segment depression. Diffuse ST segment elevation meaning almost all of the leads show ST segment elevation, and there will be chest X-ray history along with prodromal history of some viral illness. Then you suspect pericarditis. Along with this, if there is elevated troponins, then it is myocarditis. Okay, moving forwards. So this is the last thing we will conclude over here. So if there is myocarditis, same as above, but there are increased troponins along with the diffuse ST segment elevation and decreased PR segment, along with symptoms and signs of heart failure and decreased ejection fraction. What are the symptoms and signs of heart failure? There will be breathlessness, there will be increased JP, there will be hepatic congestion, there will be pedal edema. These are symptoms and signs of heart failure. So other GI causes can also present with chest pain, like esophagitis due to GERD and esophageal spasm, peptic ulcer disease, gallbladder disease, subdiaphragmatic pathology. Any patient with pleuritic pain should undergo abdominal examination and investigations accordingly. So this is given in Davidson, that any patient having pleuritic pain should always undergo abdominal examination, as many abdominal causes present with pleuritic pain. That's why any patient presenting with pleuritic pain should also undergo abdominal examination. So what investigations we'll do? We'll do UJ endoscopy and ultrasound abdomen. What is the treatment in brief? What is the treatment? So in brief, treatment depends upon the type of underlying cause. If it is angina, so remember, if it is typical angina, you will do angiography. If it is atypical or non-anginal pain, then you will plan for either coronary CT coronary angiography, or stress test you will do. Then upon if in these two, if it shows moderate to high risk, then you will go for angiography, where in case of atypical or non-anginal pain. Okay. And accordingly, if there is any if the vessel is blocked more than 75%, then you will do stenting by elective PCI. And if someone is not uh, if there are contraindications for PCI, or someone is not willing for PCI, then you can give conservative drug therapy like beta blockers plus calcium channel blockers. So Oxford says if the patient is okay on beta blockers and calcium channel blockers, then it is okay. If the patient is not responding to beta blockers and calcium channel blockers, meaning he is having pain even on beta blockers and calcium channel blockers on combination, then in angiography should be done and stent should be PCI should be done. And if still if the patient is not willing, then you can add nitrates to this, long acting nitrates to this. Okay. Other drugs which can be given in angina are nicorandil potassium channel opener and ranolazine, 500 mg BD, 500 mg BD. Okay, Nicos available in 5 or 10 mg OD, trimetazidine. Okay, nitrates like nitroglycerin, either 2.6 mg or 6.4 mg once daily you give. Beta calcium channel blocker like atenolol plus amlodipine, or in recent days you can give nebivolol, vasodilatory beta blocker, nebivolol plus cilnidipine. This is the more promising, more evidence based beta plus calcium cilnidipine combination which are used nowadays. So if the patient is having MI, then if it is STEMI, then you will plan for percutaneous coronary intervention or thrombolysis or CABG depending upon the condition. And if it is an NSTEMI, you give injection glomerular heparin along with aspirin, clopidogrel. Further decisions are based on TIMI score and GRACE score, and if in these scores score, if the risk is moderate to high, then what you will do, you will again do PCI, you will elective PCI you will perform in this patient. Okay. Next is acute pericarditis and myocarditis. You will give NSAIDs and steroids. Aortic dissection, cardiovascular surgeon. Pneumothorax, you will insert ICD into the chest, give oxygen and treat the cause. In esophageal or peptic perforation, you do surgery, gastroesophageal surgery. If GRD and PUD, you give proton pump inhibitors, and in peptic ulcer disease, you give H. pylori eradication therapy. If again the patient is having pain after giving PPS and H. pylori, you can try amitriptyline also in low doses like 10 mg QD night. In musculoskeletal pain, you give NSAIDs, muscle relaxants, steroids, and if the patient is having herpes zoster, then you can give acyclovir at a dose of 800 mg 5 times daily, 5 times. Or if you give valacyclovir, you can give 1 gram TID. Okay. In radicular pain, meaning some cervical neuropathy or spondylosis pain, you can give pregabalin, duloxetine, amitriptyline. Other cases you can treat accordingly. So by this we end the topic of chest pain. Thank you.